Diseases of the pleura. This will be the last lecture in our lectures for this year, and welcome everyone. To start with, and just to talk about and remind you about the anatomy and physiology of the pleural space. As you know, the pleura consists of two layers: the visceral pleura, which covers the lungs and interlobar fissures, and the other part is the parietal pleura, which lines the ribs, diaphragm, and mediastinum. There is a double fold of pleura which extends from the hilum to the diaphragm and forming the inferior pulmonary ligament. And you know that we have inferior pulmonary ligament and we don't have superior pulmonary ligament. That's why when the lung is collapsed in case of pneumothorax, you will see that the lung is at the level or even lower than the level of the hilum because of the presence of the inferior pulmonary ligament. There is no communication between the two pleural cavities, as it was mentioned before. Nowadays, most of the books and the anatomy mention that there is no communication between the two parietal or pleural spaces. The space contain pleural space contain 2 up to 10 ml of pleural fluid in the normal individual. The parietal pleura, which lines the chest wall, mediastinum, diaphragm, and form the cobula or pleura dome, are the thoracic inlet bilaterally, and the dome of the pleura is above the level of both clavicles. So when someone asks you to do auscultate or to do percussion for the as a part of chest examination, you have to start from the supraclavicular region. The diaphragmatic pleura adheres tightly to diaphragm. The mediastinal pleura adherent tightly to pericardium, and the dome of the pleura, costal pleura, can dissect it from the underlying tissue. So regarding the parietal pleura, which covers the costal, the ribs, which lines the ribs, we can separate it from the underlying tissue, and sometimes we need to do pleurectomy and in cases of some of the operation when we need to do pleurectomy to allow adhesion between the lung and chest wall to prevent recurrence of whether effusion or collection of air or fluid. As you see here, the visceral pleura, which lines the or covers the lung, and the parietal pleura lines the costal or the ribs. Here we have pleural cavity between the visceral and parietal pleura. The visceral pleura arterial supply is from the bronchial and pulmonary arterial system. The venous drainage is to the pulmonary veins. The parietal pleura arterial supply is from various systemic arterial supply of the chest wall, diaphragm, and mediastinum. Venous drainage is directly into the superior vena cava. Lymphatic drainage of the visceral is to the pulmonary plexus, located in the interlobar and peribronchial space. Direct subpleural lymphatic connection to mediastinal node is possible in 20 to 25% of population. Lymphatic drainage of parietal pleura is to the parietal pleural lymphatic channels, the stomata, and around the cambier foci. The lymphatic network of the chest wall drain into internal mammary chain anteriorly and intercostal chains posteriorly. The drainage of the diaphragmatic pleura is to retrosternal and mediastinal and celiac lymph node. Parietal pleura is innervated by both somatic, sympathetic, and parasympathetic fiber via the intercostal nerve. The diaphragmatic pleura is supplied by phrenic nerve. The visceral pleura is devoid of any somatic nerve supply. Manifestation of diseases of the pleura include either the patient during workup found to have pleural effusion or pleural thickening, which may or may not be calcified, pleural air within the pleural cavity, which is pneumothorax, pleural neoplasms. Primary disease of the pleura is rare. Most pleural abnormalities results from disease processes in other organs. Pleurisy. By definition, pleurisy is an inflammation of the pleura characterized by exudation and no significant degree of effusion. Causes may be due to primary pleural disease like tuberculosis, rheumatic fever, viral diseases, malignant condition like mesothelioma, or secondary due to lung disease, pneumonia, tuberculosis, lung abscess, or pulmonary infarction, mediastinal disease, pericarditis, mediastinitis, and malignancy, subdiaphragmatic disease like amoebic or subphrenic abscess. Clinical features, symptoms. A patient with a pleurisy or pleural problem may presented with pleuritic pain. Patient with pleurisy may presented with pleuritic pain, which is sudden, stitching chest pain, increasing with inspiration, coughing, or and movements. In diaphragmatic pleurisy, the pain is referred to the shoulder through the phrenic nerve, or to the epigastrium and lumbar region through the lower intercostal nerves. So pleuritic pain, pleuritic cough, which is dry due to irritation of pleura, dyspnea due to restriction of respiratory movement, and underlying lung disease or development of effusion. Specific etiological and general features like fever, headache, and malaise may be an presentation. Signs. By inspection, you will see there will be limitation of movement on the affected site. On palpation, sometimes palpable pleural rub. On percussion, there is tenderness. By auscultation, pleural rub. If you go to diagnosis, so you need to do investigation. One of these investigations is chest X-ray, which must be performed in every case for detecting a thoracic cause for the pleurisy. Pleural plaque and calcification. Pleural plaque are discrete areas of thickened parietal pleura, often bilateral, more common on lower half of thorax, don't occur at apex of the chest, don't cause adhesions, appear smooth and ivory white, may be nodular and grayish brown. This is another condition that affects the pleura, pleural plaque and calcification. Histologically, uniformly arranged, densely laminated collagen, relationship with mesothelioma uncertain, and common finding on X-ray, differential diagnosis, any pleural tumor. Other condition of the pleura that affect the pleura is pleural cyst. Pleural cyst most common at pleuropericardial angle, 70% on the right, unilocular up to 10 cm in diameter, typically water density on chest X-ray and CT, slowly growing, rarely symptomatic, removed for diagnostic purposes. Pleural masses, benign like lipoma, pleural fibromas, and rounded atelectasis. Malignant pleural masses due to metastasis, most common. Other less common causes, lymphoma, thymoma, asbestos-related malignant mesothelioma. Here, 39 years old female with no significant past medical history. Chest X-ray shows an rounded mass on the pleural-based mass on the upper zone of the right hemithorax, and by PA and lateral view. So this is an example of benign pleural fibroma after resection, and you will send for histopathology just to know the type of this mass. Pleural lipomas are benign soft tissue neoplasms that originate from the submesothelial layer of parietal pleura and extend into the subpleural, pleural, or extrapleural space. Are soft, encapsulated, fatty, slow-growing tumor. By CT may appear like a fat attenuation, approximately if lesion is close to the diaphragm, may be mistaken for hernias like Morgagni and Bogdalic hernia. "70-year-old man, patient, admitted with chest pain, dyspnea, and cough, and there is by chest X-ray bilateral haziness on the lateral or the peripheral part of the chest, pleural based, and by CT shows these two masses posteriorly, which is pleural lipomas. Mesothelioma, one of the important subjects, that we have to think about. And it is a primary tumor, usually carry high mortality caused by asbestos exposure. 5 to 7% of all individuals exposed to asbestos, latent parietal or latent period 20 to 40 years. 50% of patients no history of asbestos exposure. Asbestos زائد and cigarettes smoking increase lung carcinoma risk. Malignant pleural mesothelioma is tumor that develops from the protective lining covering the outer lining of the lungs and internal chest wall due to exposure to asbestos. X-ray show unilateral concentric plaque-like or nodular pleural thickening. CT shows in details involvement of mediastinum and diaphragm and chest wall. MRI show the plaques as hyper intense, less than muscle. Usually found incidentally by chest X-ray, common in the 4th to 6th decade of life, with history of asbestos exposure. Presenting symptoms 50 to 60% asymptomatic. Other symptoms dyspnea, chest pain, and hemoptysis. Most behave as slowly growing, paleless masses, associated hypertrophic pulmonary osteoarthropathy, and episodic hypoglycemia due to production of insulin-like growth factor may be present in 4 to 5% of cases. 80% arises from visceral pleura and 20% from parietal pleura. Calcification present in less than 5%. Central necrosis is common in the larger tumors. What investigation you need to do to reach the diagnosis? So the diagnostic workup includes chest X-ray, CT scan, aspiration, pleural aspiration, bronchoscopy, pleural biopsy, closed, open, or by busts. This is an 49-year-old patient presented with no symptoms or tightening chest pain at time of presentation, and you see on the right side there is thickening of the pleura with obliteration of costophrenic angle. By CT you can see there is an mass located posterolateral. It is pleural based. So the patient need investigation to reach the diagnosis, and mostly it's he is a case of mesothelioma. Management of mesothelioma, either surgical resection or by brachytherapy or by external radiotherapy, interactivity radiotherapy, intracavity radiotherapy, chemotherapy, combination therapy, all are usually considered palliative. So for those patients with mesothelioma, all these measures may be considered as a palliative. Pleural effusion. What's pleural effusion? It's abnormal, excessive accumulation of fluid inside the pleural space. Normally, it contains up to 20 ml of fluid. It is shown on X-ray or can be seen. You have finding in the X-ray if it is more than 300 cc. Radiologically can be detected, while clinically, if it is more than 500 cc, so you have clinical finding. It's either exudate, protein content less than 30 gram per liter, blood stained effusion, usually malignant. 50% of malignant effusions are serous. The physiologic mechanism in the development of pleural effusion: increase in hydrostatic pressure, decrease in osmotic pressure, decrease in pleural pressure, atelectasis, increase in permeability of microvascular circulation, inflammation, impaired lymphatic drainage as in tumor, transport of fluid from abdomen as in ascites. Etiology and pathogenesis: either exudate or transudate. Exudate one or if it had one or more of the following criteria: pleural fluid protein to serum protein ratio more than 0.5, pleural fluid LDH to serum LDH ratio more than 0.6, pleural fluid LDH value more than 2/3 upper normal limit for serum LDH, pleural fluid LDH more than 200 unit per liter. Causes of exudate: infection like pneumonia and parapneumonic complication, cancer, especially mediastinal, pulmonary embolism, rheumatic fever, empyema, tuberculosis, connective tissue disease, viral pleurisy, acute pancreatitis, uremia, chronic atelectasis, sarcoidosis, drug-related postmyocardial infarction, and mesothelioma. All these cause exudate. Transudate: pleural fluid protein to serum protein ratio less than 0.5, pleural fluid LDH less than 200 units per liter. Causes of transudate: congestive heart failure in majority of cases, cirrhosis with ascites, nephrotic syndrome, myxedema, so systemic causes, acute atelectasis, constrictive pericarditis, superior vena cava obstruction. What are the clinical features in patients with pleural effusion? Shortness of breath, decreased chest wall movement on examination, tracheal shifting of trachea by X-ray clinically, stony dull percussion note, dull or stony dull percussion note, reduced or absent heart breath sounds, and signs of underlying cause accordingly. Symptoms: pleuritic pain, pleural rub, irritative dry cough, dyspnea, severity increase with the size of the effusion. If it is more, the dyspnea will be more. General symptoms due to the cause: fever, night sweat, loss of weight, loss of appetite. Signs: by inspection, there is limitation of movement in the affected side. By palpation, there is large effusion shift the mediastinum to the opposite side, and there is decreased tactile vocal fremitus. And on percussion, there is basal stony dullness rising to the axilla, hyper-resonant above the level of effusion, and by auscultation, absent or reduced breath sounds over the area of the effusion. Bronchial breathing and egophony may be heard over the upper level ml of fusion. Physical findings are absent if the less than 2 to 300 ml of pleural fluid is present. So if it is more than 500 cc, at that time you will have clinical finding. Radiological finding: standard X-ray free pleural fusion demonstrate a meniscus sign, which is a concave upward sloping interface with the lung that cause sharp or distinct blunting of the costophrenic angle. So meniscus sign is very important. Here, this X-ray on the left side, you see obliteration of costo and cardiophrenic angle with meniscus sign. So these are the important findings to say that this is an pleural effusion. So obliteration of costo and cardiophrenic angle with meniscus sign. Here, another patient with pleural effusion on the right side. Again, obliteration of costophrenic and cardiophrenic angle and meniscus sign. Another case of effusion. Here, there is complete opacification of the left hemithorax with shifting of mediastinum to the other side. So this is a massive effusion. Produces complete or nearly complete opacification of hemithorax with displacement of the mediastinum to the opposite side. Chest X-ray shows obliteration of costophrenic angle by a homogeneous intense opacity raising laterally to the axilla, mediastinal displacement to the other side. May indicate the possible etiology of the pleurisy, tuberculosis, lung cancer, lymphoma, showing the primary mediastinal lesion. This is by X-ray. Sometimes we need to do thoracentesis to reach the diagnosis. Pleural fluid is examined for physical, chemical, bacteriological, and cytological examination. We aspirate fluid and send it for cytological examination, AFB, culture sensitivity, and so on. Pleural biopsy is needed, blind or image guided, and send the biopsy for histopathology to reach the diagnosis. And other investigation: ultrasonography, contrast, enhanced CT of the chest, bronchoscopy, and sometimes you need to do medical or surgical thoracoscopy. Differential diagnosis of fusion: basal lung lesions like basal consolidation, collapse, subdiaphragmatic disease, amoebic liver abscess, subphrenic abscess, and the complications of fusion: respiratory chronic distress, secondary infection causing empyema, fibrosis, fibrous layer formed and called peel, and this end with what's called trapped lung, permanent lung collapse. We have other special types of pleural effusion, like malignant pleural effusion, which develop due to malignancy like mesothelioma or other malignant condition. Cytology examination of the fluid or pleural tissue biopsy reveal evidence of malignancy. The pleural fluid is hemorrhagic with a rapid reaccumulation. Paramalignant pleural effusion and an apparent cancer or visible but not pleural, the pleural space being not directly invaded by tumor. Parapneumonic pleural effusion, any patient with pneumonia which not treated well and become complicated. The patient develop parapneumonic effusion, and this effusion may become infected and become empyema. So the treatment of pneumonia is important to prevent such a complication. Tube thoracostomy is required for parapneumonic effusion if any of the following is present. The fluid resembles frank pus. Pleural fluid glucose is less than 40. Pleural fluid pH is less than 7.2. Pneumonic effusion that does not respond to drainage within 24 hours may have become loculated. Empyema is exudative pleural effusion caused by direct infection, usually bacterial, of the pleural space, frank pus pleural fluid. The main cause, bacterial pneumonia and lung abscess. Pleural fluid pH is less than 7.2. Milky in appearance pleural fluid, clearing the supernatant after centrifuge. Hemothorax is the presence of frank blood in the pleural space, and hematocrit of the fluid is more than 50% of the hematocrit of peripheral blood. Hemothorax is present if these are present. Causes chest trauma, cancer, or pulmonary embolism. Patient with a hemothorax in the right side. Chylothorax, chylus pleural effusion, occurs in chylothorax as a result of disruption of the thoracic duct traumatically or by cancer invasion. The pleural fluid is turbid post centrifugation. Triglyceride is more than 10 milligram per deciliter. Prognosis depends on the etiology and the prognosis of the underlying disease. In malignant effusion, the prognosis is poor. The rheumatic fever or viral pleural effusion have usually better prognosis, often solving spontaneously. Treatment, transitive need treatment of underlying condition. Exudative treatment of if it's parapneumonic, treat underlying pneumonia by drainage or by chest tube. Empyema and hemothorax need chest tube drainage. Malignant depend on symptoms and frequent repeated thoracentesis, frequent chest tube drainage. Some patients need pleurodesis. Chemical pleurodesis by using tetracycline, talc, or bleomycin. Treatment of the underlying medical condition that's causing pleural effusion. To treat pleural effusion in general. Treatment by thoracentesis, therapeutic and diagnostic, tube thoracostomy, chest tube drainage, insertion, pleural catheter for reoccurring pleural effusion, pleural sclerosis, pleurodesis to minimize the rate of recurrence, surgery by VATS or by thoracotomy. Antibiotics, if are indicated, should be guided by bacterial culture results. According to the culture and sensitivity, we use antibiotic. Pleurodesis is considered for patients with uncontrolled and recurrent symptomatic malignant effusion, and rarely in cases of benign effusion after failure of medical treatment. We use talc, tetracycline, or doxycycline, bleomycin, is instilled into the pleural cavity through the tube, chest tube, to produce a chemical sclerosis and subsequent fibrosis of the pleura. So you will end with an adhesion between the visceral and parietal, or between the lung and chest wall. So you will minimize the rate of recurrence. Drainage of empyema is usually by insertion of chest tube underwater seal, large catheter inserted into the site of pus accumulation. Loculated fluid post drainage continued for 1 week. Chest tube kept till drainage is null or less than 30 ml per day. Patient with a empyema insertion after insertion of chest tube, before and after insertion of chest tube, you see the difference. Before, there is complete opacification of right hemithorax. After the insertion of chest tube, there is expansion of the lung, but there is remaining some collection or even thickened pleura. Pneumothorax, when you have air fluid levels, so you have to think about pneumothorax, which is here on this X-ray on the left side. Pneumothorax, presence of gas in the pleural space, either spontaneous pneumothorax, primary, secondary, or traumatic, or iatrogenic, or tension pneumothorax. So the causes either due to rupture of pleural bleb, penetrating or non-penetrating trauma, pneumonia and parapneumonic complication, asthma, cystic fibrosis, COPD, bronchitis, inhalation of some toxic substances, most notably crack cocaine. Transthoracic aspiration needle aspiration may end with pneumothorax, thoracentesis, central intravenous catheter, mechanical ventilation, resistive force. All these may cause pneumothorax. Tension pneumothorax. What's tension pneumothorax? Tension pneumothorax. Tension pneumothorax, presence of large lung or bronchial injury, cause air leak. The air will the site of air leak act as a one-way valve, allow the air to enter the pleural cavity but not allow it to return back. So with time there will be progressive accumulation of air within the pleural cavity, causing lung collapse and shifting complete lung collapse on the ipsilateral lung side, with compression on the contralateral side with shifting of mediastinum. Like this, complete collapse of ipsilateral lung with shifting of mediastinum and compression on the contralateral lung. Common causes of tension pneumothorax: penetrating trauma, CPR, ventilated patient, signs and symptoms: tachycardia, hypotension, patients with pneumothorax, complication, subcutaneous emphysema, X-ray of a patient with a pneumothorax. Before, you see complete collapse of the left lung. Here, complete collapse of the right lung. Management of patients with pneumothorax, diagnosis, clinical and radiological. Chest X-ray is important. Treatment, if it is small, stable, primary spontaneous pneumothorax, less than 15% of hemithorax, so observation with oxygen, and sometime you need to do aspirate this air. Other than this need chest tube drainage. Thoracoscopy, thoracotomy, plus minus pleurodesis, recurrent spontaneous pneumothorax, surgery if all other procedure failed, and patient should quit smoking. And thank you.